Dr. Cingolani is a native from Argentina, and where he did his medical training and trained as a cardiologist there at a sister institution, the CEMIC, which is an institution with which we have shared some faculty and rotations in the past. And then he went on to do a postdoctoral research fellowship at Johns Hopkins in one of the premier labs in basic electrophysiology with Dr. Marban. And then he went on to retrain in internal medicine and in cardiology at Hopkins and then at Cedars-Sinai, where he's been for the past few years conducting basic and translational research in electrophysiology. He combines his research activities with clinical activities as an EP, and that gives him unique insights. And his work has been dealing with the creation of a biological pacemaker, which is something that there's been a lot of talk in the past, I would say 15 years, but he's the one that is taking the idea closest to a clinical reality.
Thank you very much for the invitation, and Sumin and Miguel for a great hospitality. It's a pleasure to be here. As an outline of what I want to talk about today, I'm going to be going over electronic pacemaker and the limitations. Also, the different biological pacemaker approaches that we and others have studied, including cell-based versus gene-based. Talk about the functional re-engineer versus a somatic reprogramming approach, and also the importance of delivery systems, especially when we want to translate this to clinical applications. And at the end, I'm going to finish with a clinical case and a hypothetical solution that the biological pacemaker may be useful for. As we know, pacemaker has been around for over 50 years now, and they've been indicated for multiple clinical conditions, including sinus node dysfunction and atrial ventricular block, and those patients will have a syncope of rhythmic origin. There's been constant improvement with the device technology, moving from the old pacemaker, the first pacemaker that was ever invented, and now we have leadless pacemakers and subcutaneous defibrillators with completely extravascular systems. So the technology keeps evolving, and there are devices that they work quite well. But there are, however, some limitations and complications from the pacemakers, the electronic pacemakers. The lack of autonomic response, for example. Different device companies have algorithms to try to mimic that, but they are not physiological. There are problems in the pediatric population where the children grow and they need generator changes or even lead changes. They can have lead fractures or dysfunctions or generator malfunctions. There are like a problem in congenital heart block in utero specifically. I won't be talking about today, but that's a very special population. And infections, it's a rare but a very complicated problem as well. This is a single center experience which show the incidence of pacemaker-related infections. It's believed to be 2 to 3%, and the common denominator, as we all know, is that the patients need not only antibiotic treatment, but complete removal of the system in order to treat the infection. The rate of infections keeps growing in the United States and worldwide, not only as a factor of the increased number of implants that we do, but also with the appearance of more resistant organisms that are more difficult to treat. And this is true for both ICDs and BIVs and dual chamber pacemakers. Infections, as we know, they can range from a pocket hematoma to erosions to frank endocarditis that they need complete extraction and surgery. But the common denominator, as I said before, is that they need extraction of the device in order to be treated. And that can create a problem in pacemaker-dependent patients where they need to be admitted to the hospitals. And nowadays we have two options. One option is have a transvenous temporary pacer when the patient has to be in the ICU monitor and it's usually not very stable and they're non-ambulatory. And the other option is to put an active fixation lead where the patients can be in a telemetry unit and it's more stable, they can ambulate, but they still need to have some hardware, and that could potentially, in theory, slow down the rate of the infection clearance because of the presence of a foreign body. So the question that we and others ask is whether biological pacemaker can be used as a bridge to a device in infected pacemaker-dependent patients. In those that they come to the hospital, they have an infection, and they are pacemaker-dependent. So for that, there are different approaches that have been used. A gene-only approach, where either a ion channel named HCN or pacemaker channel, or a mutant channel is overexpressed in a normal cardiac cell, making that cell to oscillate and create pacemaker activity or spontaneous action potentials. A hybrid approach has been used where cells are used as a delivery system to deliver those ion channels to the myocytes to, again, make oscillate that membrane and create biological pacemaker activity for a working myocyte. And a stem cell-only approach has been also used primarily with human embryonic stem cells and more recently with human iPS cells, where cells are transplanted into the heart and they capture the myocardium and they produce pacemaker activity. The first biological pacemaker was described back in 2002, where a mutant of an ion channel that holds that resting potential, in other words, holds that myocyte to be non-depolarizing, was overexpressed. And by doing that, with this KR2.1AAA mutant specific ion channel, create biological pacemaker activity. And this was reported back in 2002. And as you can see here, this is a normal action potential of a single cell. And this is the action potential with the cells that they were overexpressing the mutant. When they study the animals, you can see this rhythm coming in the animals with the biological pacemaker. There's AV dissociation because the model was complete heart block and the pacemaker was injected from the apex of the myocardium. A stem cell approach we can see here. Here we have embryonic stem cell in vitro with a multi-electrode array. As you can see here in green is an embryon body, and you can see the beating rate. And in this case was modified by overexpressing the ion channel HCN. And you can see that the heart rate, or the beating rate, I should say, it's higher in those that express the pacemaker channel comparing to those that they don't. This approach has also been validated by us and other groups where this is injected in animals and they have pacemaker activity, but for a short period of time until they have rejection for the transplant of the cell. Cell fusion is another approach that's been used. Here we can see that a fibroblast that's been loaded with the pacemaker channel can be fused to a cardiac myocyte, as we can see in green. And again, the action potential becomes the action potential that we see in the sinus node with a spontaneous activity, as opposed to the normal action potential in the working myocyte. When we did single cell patch clamp, we showed those oscillations, and we showed the typical IF current or Fanny current, which is a pacemaker current responsible for the normal activity of the sinus node. A new approach that has been used from recent review, and this has been used by other disciplines as well, it's somatic reprogramming. Instead of going to the stem cell phase, you go direct to reprogram a mature cell to another mature cell of a different type. And this we used to create pancreatic beta cells. It we used to generate new working myocytes. In our case, to convert working myocytes into pacemaker cells, and also in sensory loss has been used to improve these patients. And all these approaches have been studied in translational phases to hopefully be able to bring them to the clinic. So in our case, somatic reprogramming, as I said before, we inject a single gene, TBX18, which is going to convert that working myocyte that does not oscillate and have a spontaneous action potential, and they're going to provide multiple of the phenotype of the sinus nodal cell and create the spontaneous action potentials. Why TBX18? Well, TBX18 is an embryonic transcription factor that is involved in the development of the sinus node in embryological life. And the question that we ask ourselves is whether overexpressing by adenoviral system in this interaction of the research in ventricular myocyte could reproduce many of the key features of the sinus node. Here, you're going to see in immunofluorescence when you see connexin 43, which is a high conductance connecting or gap junction that is present in normal working myocytes. It turns out that when you overexpress TBX18, the connectin 43 goes away. And you want that because the sinus node is a very beautiful structure, would not only fire a spontaneous action potential, but it's also partially insulated from the surrounding myocardium. Otherwise, it will be silenced by the huge mass of myocardium. So you do want to have a slow conducting connexin rather than the high conductance connexin like connexin 43. When we did immunohistochemistry, here on the left, you see the structure of the myofilaments of the right atrium versus the sinus node. And this is, you can see it here, right atrium and sinus node. And you can see how TBX18 has the same disorganization of the myofilaments, very similar to the myocardium, to the right myocardium and to the right sinus node, as opposed to controls when they have disorganized myofilaments. When we study conduction velocity, this is in cells, we saw that the conduction velocity in TBX18 was slower, consistent with the decrease of connexin 43, which is a high conductance connexin, and also the spontaneous calcium transit, the spontaneous beating activity, was much higher in those cells that received TBX18 compared to controls. Moving on to in vivo. Excuse me, my computer abandoned me. Okay, excuse me about that. So in vivo, we were able to demonstrate that when we injected TBX18 into guinea pigs and isolated those cells that we can see here in the middle, they have the spindle shape that is characteristic of the sinonodal cell, as opposed to the rod shape classic of the normal myocytes. Here in the left, you can see actually 3 cells kind of clamped together that are sinus nodal cells, and they kind of mimic the morphology of the cell that's been transduced with TBX18. When we perform patch clamp, we show that TBX18, they have a spontaneous action potentials here in the middle, and they were very similar in morphology from those when we patch clamp sinus node myocytes. CFP myocytes, they have the classic action potential that is actually not spontaneous. You have to inject a little bit of current or pace that cell to be able to have that. The genetic footprint with many genes that are known to be related to the sinus node was very similar in those cells transduced with TBX18 comparing to the cells with the sinus nodal cells in the adult rat. And this has been reported in 2013. When we injected those animals in the apex with TBX18, we saw that the animals, they have a spontaneous activity, and the axis of that activity was consistent with the site of injection, as opposed to the animals that they have an escape rhythm that was non-specific, that was coming from upper to, from the base of the heart to the apex with a completely different axis. So far, I think I mentioned that TBX18-induced reprogramming can make changes in gene expression that resemble that of native SA node. They have morphological changes that resemble also native SA node. The EP changes resemble those cells, induced sinus cells, or we call I sinus nodal cells, or induced sinus nodal cells. And in vivo pacemaker activity was demonstrated in guinea pigs. So what about preclinical models, which is the title of my talk? Well, there are many groups, including ours and a group from Michael Rosen in New York, who's been studying these, primarily in dog or pig models. The delivery system had been different. I highlight here this study here, which is ours, when we inject pig in the AV junction using two ion channels, HCN2, which is a pacemaker channel, and KR 2.1 AAA, which is a mutant channel that holds the resting potential. And here on the bottom, the same system with TBX18 that I'm going to discuss in more detail. So the first preclinical model that we call functional re-engineer or ion channel overexpression was reported in the Heart Rhythm Journal. And the protocol includes pigs, we include a baseline EKG. All animals receive an electronic pacemaker for backup program at PVI 50. We perform AV node ablation, and then we inject both vectors using a Noga MyoStar catheter, which is a EP catheter that you can perform three-dimensional mapping, but also have a needle that you can inject biological products. It's being used largely for stem cell trials, and it's approved for investigational purposes by the FDA to deliver those products. The animals were followed for day 7 and 14 with device interrogations, ECG, and Holters. As you can see here, those that they were injected with the active transgene, they had this activity that was much higher than the other animals that remained primarily BBI-based. And here you can see the quantification that peak at day 7, 8, and they fade down at day 14, consistent with adenovirus delivery. Remember that adenovirus are transient. The expression is known to be transient because of the immunogenicity of the vector. If you want the long term, we are working with other vectors such as adeno-associated virus, which can give you a longer term biopacer. To confirm that the pacemaker was actually coming from the injection site, we did 3D mapping, and we showed that the conduction velocity was higher in those with TBX18, and the 3D mapping was coming from the injection site, red being early here, and that's consistent with conduction through his Purkinje system, since we are injecting in the basal septum in the his Purkinje system rather than in the free wall. Second model that we perform, we modify and make some changes to the previous model that we learned from, and it's with somatic reprogramming. And we reported that in 2014, the end of 2014, using TBX18 in the pig model of complete heart block. To be more specific and really understand the dynamics of the expression of TBX18, we made some changes. The changes that we made, first of all, we implanted the animals with telemetry to have 24/7 information about the activity, and not only Holters. We wanted to know really when the pacemaker activity started and what were the variations and so forth. We also did 3D mapping and monophasic action potential recordings, and we inject TBX18 or GFP, and we follow the animals as I mentioned before. This is just to show the injection site and how it looks in the microscopy. You can see here the injection in the posterior septum, how it looks like. However, when we did histology, we didn't see much inflammation. We see primarily the needle tract fibrosis, but we didn't see myocarditis or anything similar to that. When animals were followed, you can see here that the mean heart rate was significantly higher in TBX18, peaking at day 8, compared to controls that remain primarily BBI pace. You will notice here that some of the animals, the heart rate was above BBI 50, and that's why just after ablation, the pigs sometimes have an escape junctional rhythm that is above 50. We could not program the pacemaker at a lower rate because pigs are very prone to have bradycardia induced at torsade points and polymorphic ventricular tachycardia. So that's something that we have to program the pacemaker at 50. The maximal heart rate was also higher, and the electronic pacemaker utilization, the backup electronic pacemaker utilization, was minimal in TBX18 compared to controls, as I said before. Something important, especially when we are talking about bridge to device, is the time to onset. And since we have continuous telemetry, we were able to see that the difference was as early at day 20, which was very surprising and very interesting to us. And we'll keep studying the mechanistic reason for this, because if we compare the functional re-engineering strategy over expressing an ion channel versus reprogramming a cell, I think it's an important thing to distinguish which strategy would be better as a bridge to device. Diurnal changes were also very remarkable in TBX18 comparing to controls, and you can see here the raw data with multiple points because this is 24/7 telemetry compared with a very flat response in those pigs that they were primarily pace. We also did the equivalent of sinus node recovery time in those injected with TBX18, and we saw that the TBX18 animals recover pretty quickly, meaning that having a behavior similar to the native sinus node. Autonomic regulation was also a study. We study that in different ways. We study low frequency to high frequency ratios, and we can see here that TBX18, they have a normal autonomic response comparing to controls. Also, we infuse the animal with isoproterenol, and even though both animals, both experimental groups increased the heart rate with isoproterenol, there was a significant greater increase in TVX18 compared to those that were in controls. And here is the raw tracings down here. To study something beyond heart rate, the animals, actually, the system that we implanted comes with an accelerometer, the same that most of us have in our phones. And we wanted to have any measurement of whether this increase in heart rate was having any impact on the animal and the activity of the animal could perform. So we implanted a three-way accelerometer that gives you in arbitrary units the degree of activity that you are having with the animals. So as you can see here, the activity was graded in TVX18 compared to controls, right? And the burst of activity, meaning the times that the animals could stay at the higher levels of activity, was greater. In other words, the controls were able to achieve peaks, but they came right down. TVX18 were able to achieve greater activity and stay there and then come down. And this was very interesting to us and correlated to the heart rate. It's hard to say whether there's a cause effect on this, but I think it's an interesting finding because it's an endpoint that it's beyond heart rate only, and in my mind means that perhaps the animal felt better, by a better hemodynamic response and was able to achieve higher levels of activity compared to controls. The question again came in our second paper with somatic reprogramming, whether the pacemaker activity was indeed originated from the injection site, and we performed three-dimensional mapping, as you can see here, red being early, and you can see here that at the beginning, all the animals are paced, but during the follow-up, TVX18, they come from the high septum and they activate, and the GFP or controls, they keep being activating from the apex because they're primarily pacemaker dependent, giving us the proof that the activation site is coming from the injection site. We did pace mapping, and pace mapping resulted in a good match with TVX18 comparing to control. And our telemetry system has also a morphology analysis, and the percentage of match was very high with TVX18 comparing to the control group. We then want to see if the histology and the genetic footprint that we observed in our previous studies was also seen in the pig model. So we isolated both cells and did real-time PCR in those animals, and you can see this spindle-shaped cell in TVX18 compared to the rod-shaped classic myocyte that you can see here. The mRNA expression was pretty high at the injection site and minimal, less than 10 copy numbers, and this is real-time PCR, so it's very sensitive assay in the distant myocardium. So most of the transgene has been in the injection site with minimal in the distant myocardium. There's a small amount, I think I'm not going to show this data here, but there's a small amount that goes through the lungs, but again, less than 10 copy numbers, and a small amount that goes to the liver as well, and it's less than 10 copy numbers. When we perform the genetic footprint in those animals, we've seen again what we saw before in cells and in guinea pigs, and that's elevation of the pacemaker channel, HCN4, which is a funny current responsible for spontaneous activity, downregulation of connexin 43, which is a high conductance connexin that is present in the sinus node. Connexin 45 was IgH, KR2.1 that was first reported was downregulated, and NKX 2.5 and the sodium channel are also downregulated, and these are all features of the sinus node. And I think in my mind, the interesting thing is that to be able to reproduce a biopacer, rather than overexpressing a single ion channel, we need multiple things to achieve that. And it looks like TVX18, I'm not saying that it's doing all of the features, but probably, that's too complex to say because the sinus node is a very complex structure, but it's achieving multiple of the features from the EP perspective in those cells, including funny current increase, decreasing high conductance connexin, and decreasing KR2.1. That is that current that stays, your resting potential stays lower and enables the cell not to depolarize. When you knock down KR2.1, you have spontaneous activity. So here we are overexpressing pacemaker channel, decreasing KR2.1, that favors spontaneous depolarizations. We are decreasing the gap junction that have high conductance to avoid sourcing phenomenon or silencing of pacemaker activity, and sodium channel is also decreased. We wanted to make sure that there was no proarrhythmic effect, especially because KR2.1 downregulation has been linked to one of those long QT syndromes. Even though this is a very focal injection, we wanted to make sure that. We started first with imaging, and by legal linear enhancement, we couldn't see any infiltration of fibrosis at the injection site. By pathology, we did see fibrosis along the needle tracts, but we didn't see a big area of inflammation that would give us any concern about the proarrhythmic effect of the injection site from the mechanical perspective of the delivery of the transgene. To study in more detail arrhythmias and biodistribution, the animals were followed with telemetry. As I said before, there was no significant changes with sustained ventricular arrhythmias being lower, a trend towards being lower in TBX, but not significant. The incidence of arrhythmias by programmed ventricular stimulation and the end of the protocol was not significant. We studied QT interval and QT dispersion, and there was no differences. And then we also studied about monophasic action potential, which is a way to study the action potential in vivo with a special catheter that you can actually have these nice tracings and study the duration of the monophasic action potential and the dispersion. That was also not significant. Here I have the data that I mentioned before about the biodistribution. And as I said, most of the virus that is injected, most of the transgene is in the injection site. There's very tiny here in the lungs and very tiny here in the spleen with very low copy numbers. And the pathology didn't reveal any infiltration or inflammation in those organs, although I'm not going to show that for the sake of time. We did biochemistry analysis in those animals. As you can see here, there's no major changes in liver function, CK, or white count or hemoglobin in those experimental groups. So far, I think I show you that we have a delivery system that is all right-sided, as opposed to the groups that they are delivering either by open chest or by a carotid injection. We believe that getting arterial access only to deliver a biological pacemaker is kind of not needed. And with this technique, only with a single access, you can go with a catheter and inject into the upper septum and deliver it with only one single access, and it's venous access all in the right-sided heart without accessing the left side of the circulation. Something that is very interesting and became very interesting to us that we haven't published yet, that we reported in Heart Rhythm Society in AHA, is the fact that the animals that they become RV pace, if you leave them long-term being 4 to 6 weeks, they develop desynchrony, RV pacing induced desynchrony, and RV pacing induced cardiomyopathy. When we had those animals injected with TBX18, those animals did not develop that, which is consistent with conduction through His-Purkinje rather than being RV pace. Here, I hope you can see the difference in the labels are not shown here because they're underneath the screen, but this is a control animal on the left, which you can see that the function and the desynchrony, I think, is pretty evident compared with the TBX18 animal here on the right, okay? Not going to be showing rescue data, but we now have a other set of animals where we're actually inducing RV dysfunction, and once the animals have RV dysfunction, we deliver TBX18 into the high septum, and we are able to rescue this phenotype. It's not only that it's preventable, which wouldn't be that clinically useful, but we can rescue the phenotype by injecting the TBX18 to the high septum, the animals recover the function and the synchrony. When we did the synchrony analysis by MRI, we showed that there was a significant difference at 2 months in TBX18, here on the left, compared to controls by using a prototype software that we have in our MRI system. Why do we think that this is happening? As I said before, we did some high definition mapping using a array system, and we were able to see that those animals transfused with TBX18, they activated in the same way or a similar way that the normal sinus rhythm, activating both ventricles simultaneously, as opposed to the RV pace animals, when you have full activation of the right ventricle first, and then transeptal activation to the left ventricle, creating the synchrony. So I think this is quite exciting to me, and it's equivalent to perhaps his bundle pacing, where you can actually resynchronize the heart by having a biological that conducts through the normal conduction system, as opposed to having RV pacing with delay and desynchrony and induced cardiomyopathy. So what are we with the timeline of the biological pacemaker? Well, I think we made good progress. Slide is not showing the date. So this is 2002 here. I can see my screen, but not there. So this is 2002. In 2002, the first biological pacemaker was published by Functional Reengineering. This is 2008, where the cell fusion approach was described as well by other group. I think in 2012, we were able to have this minimally invasive delivery system where everything was delivered through the right side with venous access by the MyoStar catheter. Then we described the minimally invasive delivery system and then somatic reprogramming by TBX18 in cells and in small animals. We reported that we could do that also in animals with complete heart block. We did have a pre-IND conference with the Food and Drug Administration where we show our data and they make great suggestions about how to proceed to continue to work towards getting this technology towards the clinic. Then we reported in 2014 the paper about our findings in the short-term study. And long-term has been reporting both in AHA and HRS, and the synchrony study has been reported in HRS, as I said before. And right now we are in the process of long-term studies, hoping to be able to, with the information that we have from the FDA, be able to gather the information and do the long-term toxicology studies that we need to create the first in-human trial for a biological pacemaker. So back to my original question, which is, are we ready for the clinic? Okay, I think there are three very important considerations that we need to make. Number one is the biological. I mentioned to you that it can be cell-based, functional reengineer or ion channel overexpression, or somatic reprogramming. In my mind, the cell-based approach, it's not likely to be easy to be translatable for multiple reasons. Number one, the cells, even the iPS and the embryonic stem cells are immature and they have the potential to cause tumors. Number two, you will have to deliver those cells by a minimally invasive system, and it's very difficult with the catheter because you need to deliver a clump of cells, so you basically going to have to do an open heart surgery to be able to transplant that group of cells. And number three, the cells are known to migrate, specifically mesenchymal stem cells are known to migrate around from the injection site, so that's problematic. Functional reengineer is a reasonable approach, and of course, since I've been working this cell-based, to me, it's not very favorable, and I'm going to favor TBX18 somatic reprogramming, and the bar is crossing it, but it's supposed to be highlighting it for a computer effect. Yeah. So delivery systems, I don't think no one in this room will want an open chest for having a temporary pacemaker. And I think the left-sided intra-arterial approach is too invasive for a biological pacer. And I do favor the right-sided approach where percutaneous delivery without having arterial access is used. Regarding the patient population, I think this is a key question. Because I think, as I said before, devices, they been getting better and better by the hour. We now have leadless pacemakers, we have subcutaneous defibrillators, we'll soon have subcutaneous defibrillators capable of doing anti-tachycardia pacing with the leadless pacemakers, so they keep to getting very good. So I think ethically, it's important to find a population that they need a solution to start with this, to see if this technology works. In my mind, there are three populations. The pediatric population could be one. The fetal population with congenital heart block intrauterine, it's another interesting one. And device-related infections are also interesting because, as I said before, those patients, they need complete removal, and those patients dependent, they need to stay in the unit or in the telemetry unit with an active fixation lead. Some centers, I know that they send those patients home with a PICC line, with the active fixation lead, but it's not, we don't do that. I don't know, I don't think many centers are comfortable sending those patients home, even though they have an active fixation lead. So to finish with a clinical case, this is a 65-year-old male that had an aortic valve replacement 1 year prior, that came to the emergency room with fever and shortness of breath. The positive findings on the physical exam include the variables S1 and Canon AWEFs and bilateral crackles. When they quickly did the EKG and the AR, they showed complete heart block with the right bundle morphology, escape rhythm, and a TE performed in the emergency department show an aortic root abscess. Okay, so the patient underwent a temporary pacemaker right away in the emergency department and started antibiotics. He went for surgery and received an aortic graft because the abscess extended to the aortic root and not only the valve. Was 100% pacemaker dependent in the post-op period, being paced to the epicardial wires. As we know, those wires, they achieve high threshold quite quickly. So in the post-op period, they were unable to capture. Reason why he had to receive an active fixation lead or a perm 10 pacemaker. He received 14 days of antibiotics until he was able to receive the permanent pacemaker at the end of the procedure. So in our case, and this is hypothetical, if this concept proves to be effective and safe, we could have said that that patient could have had the surgery and with a single right-sided access have the biopacer delivered, provide temporal junctional rhythm until the infection is treated with antibiotic for 2 weeks. And this will be hardware-free because you don't have any indwelling hardware. You only have the biological that it's functioning. It wouldn't need ICU. If this proven stable, you can even think about the PICC line and home antibiotics where the patient is recovering from that until it has to come back to the hospital to get a new permanent device after the infection is treated. Okay. So to conclude, I think I show you that somatic reprogramming by TVX18 create a stable biological pacemaker, resulting in minimal backup electronic pacemaker use and increased physical activity in our preclinical model. The biopacer was delivered by a minimal invasive delivery system, bringing this approach closer to human translation. No evidence of local systemic toxicity during follow-up. I show you data from the published data that it's 2 weeks. We have 6 weeks data now that there's no evidence of toxicology or toxic effects in those animals. And I think long-term efficacy and safety studies with GMP or clinical grade vectors are planned prior to conduct the first in-human trial for a biological pacemaker in pacemaker affected with pacemaker infections. So I'd like to thank the people who did the work, Yufeng Hu, a great fellow that I have from Ken Xian's lab, James Dawkins, Yong Zheng, Liz Sanchez, and Shay Cho, Hee-Chol Cho, long-time collaborator, my mentor, Eduardo Marvan, and funding agencies here on the right. And thank you very much, and I'm happy to take questions.